You are tired in a way that sleep does not fix, your muscles cramp at 3 in the morning, your thinking has slowed in ways that concern you, and when you bring it up at your appointment, you are told this is part of getting older. I want to offer a different possibility, because in a significant number of cases I have reviewed over decades of clinical practice, that fatigue, those cramps, that cognitive slowing, are not aging. They are the predictable, documented side effects of nutrient depletion caused by medications you have been taking faithfully for years, and nobody has connected the dots for you. If this channel has ever given you something worth knowing, hit that subscribe button right now, leave a like, and drop a comment below, because that is what keeps this kind of conversation reaching the people who genuinely need it. I'm Dr. Mercer, and this channel exists to bring you the latest evidence-based research on senior health, simplified and designed for adults over 60. Stay with me through this entire video, because by the end you will know which 5 commonly prescribed medications are associated with specific and measurable nutrient depletions, what those depletions do to your heart and your body over time, and exactly what questions to bring to your next physician appointment. Let's begin with the context that makes this conversation so important and so rarely had in a standard clinical appointment. After 60, your body processes medications differently than it did at 40. Your kidneys filter more slowly, your liver metabolizes drugs at a reduced rate. The average adult over 65 takes 4 to 5 prescription drugs simultaneously, and some take 8 or more. Each of those drugs was tested and approved individually. What happens when 3 or 4 of them are running simultaneously in a body that is already working harder than it once did is a question that almost never gets answered in a 7-minute appointment. A landmark meta-analysis published in the journal Cardiovascular Drugs and Therapy reviewed over 40 studies on drug-induced nutrient depletion in older adults and found that the combination of commonly co-prescribed medications in patients over 65 produced measurable deficiencies in key cardiac nutrients in the majority of patients studied. Yet routine monitoring for these deficiencies was performed in fewer than 1 in 5 of those patients, fewer than 1 in 5 medications that are working exactly as designed, lowering cholesterol, reducing acid, thinning blood, preventing clots, can simultaneously be depleting the very nutrients your heart and nervous system need to function. That is not a side effect your physician is likely to mention, not because they do not care, but because the system has no established mechanism to prompt that conversation. Let me now walk you through the 5 medications and the specific depletions they cause, starting with the most widely prescribed of all. The first medication is statins, including atorvastatin, rosuvastatin, and simvastatin. Statins are genuinely effective at reducing cardiovascular risk in patients with established heart disease. That evidence is solid and I am not questioning it, but statins work by blocking a pathway called the mevalonate pathway, and that pathway produces more than cholesterol. It also produces coenzyme Q10, a molecule that functions as the primary fuel source for heart muscle cells. A 2005 meta-analysis, replicated multiple times since, demonstrated that statins reduce blood levels of coenzyme Q10 by 30 to 50%, 30 to 50% depletion in the molecule that powers the organ these medications are prescribed to protect. In a real patient, that depletion manifests as fatigue that does not lift with rest, muscle weakness, and in a measurable subset of patients, a reduction in cardiac function that their physician attributes to disease progression rather than drug-induced nutrient deficit. I had a patient I will call Clarence. He was 74, retired, walked 2 miles every morning, managed his health carefully. He came to me after 2 cardiac events in 18 months, exhausted in a bone-deep way, waking with muscle cramps at 3 in the morning. His thinking slowed in ways that frightened him. 3 physicians had told him this was normal for his age. When I reviewed his complete medication list, I saw 3 simultaneous problems that had been running unaddressed for 2 years. He had been on a high-dose statin for that entire period. His coenzyme Q10 had never been tested. The question that this raises for anyone on a statin is this: should I be supplementing coenzyme Q10 alongside my statin? Write that down before your next appointment. Not should I stop my statin, simply that question. The second medication is nonsteroidal anti-inflammatory drugs, including ibuprofen, naproxen, and diclofenac. These are available without a prescription and most people consider them essentially harmless. The cardiac risk is neither minor nor hypothetical. NSAIDs block COX enzymes, and COX-2 specifically produces prostacyclin, a compound that keeps blood vessel walls flexible, prevents dangerous clotting, and actively protects the vascular endothelium, remove prostacyclin, and you remove a primary layer of cardiovascular protection. Simultaneously, regular NSAID use raises blood pressure by an average of 3 to 5 millimeters of mercury in an adult over 60 whose arterial walls are already less elastic. A sustained elevation of that magnitude raises stroke risk in ways that accumulate over years. The FDA placed a black box warning on NSAID specifically for heart attack and stroke risk. That warning is on the label right now. Clarence had been taking ibuprofen every single day for 2 years for joint pain. His physician was aware. Nobody flagged the cardiac implications of doing so alongside a high-dose statin in a patient with his history. For chronic joint pain, topical NSAID formulations deliver equivalent local anti-inflammatory effect with approximately 90% less systemic absorption. That distinction matters enormously for cardiac safety. The third medication is proton pump inhibitors, including omeprazole, pantoprazole, and lansoprazole. Roughly 15% of all adults take them, many for years, some for decades. The concern here operates through 2 separate pathways. First, stomach acid is required to absorb vitamin B12. Long-term acid suppression blocks that absorption almost completely. A 2013 study published in the journal GAP found that long-term proton pump inhibitor users had B12 levels 30% lower than non-users, in a population that is already losing B12 absorption naturally with age because intrinsic factor production declines after 60. The drug-induced deficit compounds an age-related one that was already present. Vitamin B12 is essential for metabolizing homocysteine, an amino acid that when it accumulates directly damages arterial walls. Elevated homocysteine is an independent risk factor for cardiovascular events, comparable in some studies to elevated cholesterol, and almost completely ignored in standard cardiovascular workups. B12 deficiency also presents as fatigue, memory difficulties, and a tingling in the extremities that develops so gradually it is barely noticed until it is significant. In prolonged severe cases, the neurological damage is irreversible. From a heartburn medication taken for 10 years because nobody checked levels annually. The second pathway involves magnesium. Proton pump inhibitors also deplete magnesium, a mineral involved in over 300 enzymatic reactions in the human body. For the heart specifically, magnesium regulates the electrical signals that maintain a steady heart rhythm. Deficiency is directly linked to arrhythmia and to the 3 in the morning muscle cramps that Clarence had been experiencing for 2 years. His B12 came back critically low at his review. His magnesium was at the very bottom of the normal range, technically within range, which is why nobody had acted on it. Normal on paper, insufficient for optimal cardiac function. Before I give you the action steps, I need to say something with complete clarity. Do not stop any of the medications described in this video. Do not reduce doses. Do not make any changes to your medication regimen without direct physician supervision. The purpose of this video is not to frighten you away from medications that may be genuinely protecting your life. It is to give you the specific questions that your appointments have not made room for. Abruptly stopping a proton pump inhibitor causes rebound acid that is often worse than the original symptom, driving people back to the medication immediately. Stopping a blood thinner without supervision carries stroke and clotting risks that are real and serious. Every change discussed here must happen in conversation with your physician, with your full medical history on the table. The fourth medication is warfarin. It has been prescribed since the 1950s for atrial fibrillation, deep vein thrombosis, and mechanical heart valves, and it works. It prevents dangerous clots and reduces stroke risk in atrial fibrillation patients by a clinically meaningful margin. I am not disputing that, but warfarin works by blocking vitamin K. And it cannot distinguish between vitamin K1 and vitamin K2. Vitamin K2 activates a protein whose specific function is to prevent calcium from depositing in arterial walls and to direct it toward bones instead. Without K2 activity, calcium drifts, it settles into vessel walls, arteries become progressively rigid and calcified. A 2019 study published in the Journal of the American Heart Association found that long-term warfarin users showed significantly accelerated coronary artery calcification compared to matched patients on newer anticoagulants. In patients whose physicians were actively trying to protect their cardiovascular health. As a clinician who has reviewed operative findings in patients with long-term warfarin exposure, heavily calcified coronary arteries create complications that extend from the surgery itself through the recovery and into long-term outcomes. Does this mean warfarin patients should stop their medication? Absolutely not. Untreated atrial fibrillation carries approximately a 5% annual stroke risk. That is not a risk to dismiss casually, but it does mean that two specific questions deserve to be asked at your next appointment. First, given the availability of newer anticoagulant options today, is warfarin still the most appropriate choice for my specific situation? Second, has anyone measured my coronary artery calcium score? A low-radiation CT scan provides a precise picture of the current state of your arteries and is one of the most underutilized cardiac risk assessment tools in routine practice. The fifth medication is calcium supplements, and this is the one that I find most important to address clearly because it is a recommendation given to millions of people with the sincere intention of protecting bone density. In 2010, the British Medical Journal published a meta-analysis reviewing 15 randomized controlled trials involving nearly 12,000 patients. The finding was a 30% increase in cardiovascular event risk associated with calcium supplementation without co-administration of vitamin K2 and D3, 30%, adults faithfully taking their calcium every morning because a physician recommended it may be meaningfully increasing their cardiac risk while believing they are doing something protective. The mechanism is specific. Supplemental calcium, taken as a concentrated dose, enters the bloodstream as a sudden surge, without the K2 and D3 required to direct it to bone tissue. The body does not know where to place it efficiently, and one location where it accumulates is arterial walls, producing the same calcification described in the warfarin section through a different pathway. Why have guidelines not changed more dramatically in response to this data? Reversing a recommendation given to tens of millions of patients over 20 years involves institutional complexity, liability considerations, and industries built around calcium supplement sales. Easier to add a quiet footnote than to say clearly that the recommendation was incomplete. The recommendation was incomplete. Now, what does the evidence support as a constructive approach? For patients on statins, coenzyme Q10 supplementation at 100 to 200 mg daily has been studied in multiple trials. The Q-Symbio trial showed measurable improvement in heart failure patients who supplemented it. The question to ask is not whether to stop the statin, it is whether coenzyme Q10 monitoring and supplementation should be part of your standard follow-up. For patients on long-term proton pump inhibitors, sublingual methylcobalamin at 1000 micrograms daily bypasses the absorption problem entirely since it does not require stomach acid. Chelated magnesium at 400 mg daily is far more bioavailable than the magnesium oxide found in most standard drugstore formulations. For patients on calcium supplements, co-administration of vitamin K2 as menaquinone 7 at 100 micrograms daily, and vitamin D3 at a minimum of 2000 international units, significantly modifies the cardiovascular risk profile by directing calcium toward bone tissue rather than arterial walls. Dietary calcium through dairy, leafy greens, and small fish consumed with bones should be the primary source wherever possible, with supplementation used to fill gaps rather than as the primary delivery mechanism. I want to tell you how Clarence's story ended. After reviewing his complete medication list across a 40-minute appointment, I made calls to his cardiologist and his general practitioner. We built a plan together. Coenzyme Q10 at 200 mg daily was added. Sublingual methylcobalamin was started immediately given his critically low B12. Chelated magnesium was added. His daily oral ibuprofen was switched to topical diclofenac gel at the same anti-inflammatory strength with 90% less systemic absorption. His physician began a gradual proton pump inhibitor taper. Vitamin K2 and D3 were added alongside his existing calcium. Nothing dramatic, no new surgery, no breakthrough pharmaceutical. The team simply stopped depleting what his heart needed to function and replaced what had been lost. 6 months later, Clarence called. He said he felt like himself again for the first time in 2 years. The exhaustion was gone. The 3 in the morning cramps had stopped within the first month. His cardiac follow-up showed measurable improvement in heart function. His general practitioner called me, genuinely puzzled by the improvement. Nothing had changed except that the complete picture had finally been addressed. Here is exactly what to do. Step 1. Write down every medication and supplement you take, every dose, every frequency. Bring that complete list to your next appointment. Step 2. Write 3 words at the top of that list. What am I losing? Take that question literally and take it to your physician. Step 3. Ask specifically whether any of your long-term medications have been associated with nutrient depletion, and whether monitoring for coenzyme Q10, B12, magnesium, and vitamin D has been performed recently. Step 4. Ask your physician whether a coronary artery calcium score has been measured, particularly if you have been on warfarin or calcium supplements for more than 2 years. Step 5. Ask whether any of your current medications have newer alternatives with a different risk profile for nutrient depletion or arterial calcification, and request a scheduled medication review to discuss the combination you are currently on rather than each drug in isolation. One important clarification before we close: the information in this video applies most directly to adults taking these medications long-term, meaning for 1 year or more, for chronic conditions. It does not apply in the same way to short-term use. A course of ibuprofen for an acute injury does not carry the same cumulative risk as daily use for joint pain over 2 years. Additionally, for patients with established heart disease, atrial fibrillation, or osteoporosis with documented fracture risk, the medications discussed here may be non-negotiable components of care. The goal of this video is never to create doubt about whether you need your medication. The goal is to ensure that the conversation about what that medication costs your body over time is part of your standard medical care, not something you have to ask about specifically because you watched a video. Your medications may be doing exactly what they are designed to do while simultaneously depleting what your heart needs to function at its best. You deserve to know both sides of that equation. If this video gave you something useful, hit the like button right now. Leave a comment telling me whether any of these 5 medications are part of your daily routine and whether your physician has ever discussed nutrient monitoring alongside your prescription, and share this with someone you care about who has been told their fatigue or their cognitive slowing is simply part of getting older. It may not be. Subscribe if you have not already, and I will see you in the next one. Take good care of yourselves.